Well, hello. Welcome to the Dr. Ellen Derrick podcast and office hours. My name's Ellen Derrick, and I'm a triple board certified surgeon and obesity medicine doctor physician. And today we are going to talk about diabetes and amputations. Did you know that 80% of non traumatic amputations of the lower leg in the United States of America are because of diabetes? So, diabetes is essentially when the pancreas, insulin, and the sugar that we eat do not work together to give patients energy. And let me explain. When the pancreas is working normally, and a person eats a piece of candy or a taco, the pancreas will secrete a peptide, a hormone called insulin. And insulin will signal to the muscles and the other cells that energy has just been consumed, and it will want to take the energy and store it in the muscles or use it for activity. I like to think of a lot, it's like call and response. The body is so good at regulating itself when it's working normally. When it's working abnormally, what happens is the sugar and the insulin don't communicate correctly. And so the sugar, instead of being taken and stored in the tissue that it's supposed to be stored in, it will stay circulating in the blood. And this, as you can guess, will trigger an inflammatory cascade. And over time, the inflammatory cascade from the hyperglycemia or elevated blood sugar is very, very damaging to patients, and it can cause blindness, kidney failure, and lower extremity amputation. Okay, so diabetic neuropathy or neuropathy in general plays a huge part of amputation with diabetes. Neurosurgeons and vascular surgeons argue all the time. If you ask a neurosurgeon what tissue is the most sensitive to lack of oxygen, they will immediately tell you that it is the brain. And that is why CPR is there, is to restore brain function. And they're partly correct. If you ask a vascular surgeon or a cardiac surgeon, what is the purpose of CPR? What is the most sensitive tissue to lack of oxygen? A vascular surgeon is going to tell you, oh my God, it's the feet. Or a cardiac surgeon will tell you it's the heart. And they're all correct. All three specialties are correct. But let's give some neurosurgeons some credit. Nerves that are in the feet, for example, if there's not enough oxygen being delivered because the diabetes has impacted those small vessels, then those nerves are also going to slowly die. And the way that that slow death, plays out for a diabetic patient is they get neuropathy and they lose the ability to feel the difference between 2 points. That is contributing because they may have a shoe that is ill fitting, or they may step on, if it's at our house, a Lego or a tack or something and get a small injury to the foot, and they won't have the ability to feel it, and they don't have great blood flow to heal it. And that sets the triple cascade of tissue death and potential future amputation unless oxygenated blood can be restored to that tissue area. How does the severity of diabetes impact the risk of amputation or complication? Probably the easiest way to think about it, the risk of complication from diabetes is going to be connected to the length of time that a patient has diabetes. And sometimes patients can have diabetes but not know they have diabetes. So you can ask your primary care physician to order a hemoglobin A1C, and that is a wonderful test that will give you an idea of how does your blood sugar perform over a period of time, and that can let you know if you are having hyperglycemia that you don't know about. And it is also a wonderful way to monitor if diet and exercise can impact your blood sugar, because they absolutely can. Okay, so when we think about amputation prevention, we think about it's a combination of small vessel and large vessel disease. I'll start with large vessel disease prevention. So those are going to be blood vessels in the thigh, blood vessels behind the knee, and big blood vessels in the calf. And the way to reduce your risk of amputation there is, number one, do not smoke. And if you quit smoking, do not start smoking again. Smoking is the number one modification that a patient can do. It's also the most difficult. The average effort it takes to quitting smoking and stopping is 15 attempts. So that means a patient has to try stopping smoking 15 times before they stop smoking. It's very difficult to stop smoking. The second thing a patient can do is a patient can treat their high cholesterol. A patient can treat their high blood pressure. And if a patient has diabetes, a patient can manage their diabetes. And all of those, blood sugar, managing cholesterol, and managing blood pressure, are, huge discussions in and of themselves. But just to put it in a small bow so we can think about it, those metrics impact big vessel disease. Those metrics also impact small vessel disease, but diabetes probably has one of the biggest impacts on the small vessels. It does that by impacting the ability of the small vessel to give oxygen to the tissue and for the nerve to feel if there's an injury or a problem. And so treating diabetes is a wonderful way to reduce your risk of lower extremity amputation. And there are ways to manage diabetes that are outside of our discussion today that you should have with your physician. But some low-hanging fruit are walking 6 days a week for 30 minutes. That is amazing, in the correct fitting shoes, just walking. And it doesn't have to be 30 minutes at once. It can be 6 5-minute sessions, 3 10-minute sessions. But the studies are very clear that is very good for artery disease and reducing your risk of amputation. And also eating foods that are on the low inflammation spectrum or low glycemic index. And the easy way to think about that is that if it's colorful, eat it. And if it's white, think about it. If you have diabetes, yes, the ideal plan is that it can be difficult to see the soles of your feet. It can be difficult to see in between your toes. So the ideal plan, if you have diabetes with neuropathy, is to have a family member or a neighbor, somebody that you know, look at your feet every day. Look in all the places that you can't see. The other thing to do is, when you need to get your toenails trimmed, is to go to a podiatrist. And a podiatrist can just trim the toenails, but it is important to instruct them not to cut the skin. Don't cut the skin, but it is okay to cut the nail. Question is, as a vascular surgeon, how do I work with patients to avoid amputation and reduce and improve their overall arterial health? So the first thing that we do as vascular surgeons is we talk to patients about the contributing factors that put them at risk for amputation. So smoking, movement, blood sugar treatment, blood pressure management, cholesterol management. So we first talk about all of those things. And those are modifiable risk factors that, in theory, are in control of the patient. I'm also a human and also a patient. And I know it's easy to say and it's easy to put on a podcast, but some of those behavior changes are very, very difficult to do. But that's the first thing to do. The second thing to do is, if you have symptoms of any of these things, is to go see a vascular surgeon. And they'll start by feeling if you have a pulse in your foot. And if you don't, they will also put a little Doppler there to hear the heartbeat in the foot. That's the number one first clue that a vascular surgeon gets, that maybe there's not as much blood flow down there as we would like. And if that pulse is abnormal or there's a wound that is not healing, then we'll refer a patient to get an ultrasound, and the ultrasonographer will look at the artery and give the surgeon lots of information about the health of that artery. And then your vascular surgeon will work with you, tell you the options to improve the blood flow and go through risk and benefit analysis, and ideally work with you on what your wishes and desires are. Over the course of my career, I've had patients say to me, "Doctor, just do everything to save my leg. And if I end up with an amputation, I end up with an amputation." And I've had other patients say to me, "I don't want my last 5 years of life to be all about going, as much as I like to see you, Dr. Derrick, I don't want my whole last 5 years to be all about going to the doctor to save my leg. And maybe, you've talked everything through, and maybe we just go to primary amputation. Because I walk now, I'm strong, and I ambulate, I can walk independently. And if we just go to primary amputation, I am very motivated to be fitted with a prosthetic and just walk right away so that my mobility remains unimpacted. You can go either way, and there's not a right way or a wrong way. The right way is the right way for you, and it is a very detailed risk benefit personal conversation that you should have with your vascular surgeon. And I know a lot of wonderful vascular surgeons who will take terrific care of you and really help you make the right decision for you. Thank you so much for joining me on this episode. Can diabetes lead to amputation? I think you now know yes. However, I hope after listening to this podcast, you know some things that you can do to reduce your risk. So thank you, and share this with somebody who you think needs to hear it today.